Hello, everybody. Thank you for joining us today. We are discussing about the clinical application of the Basophil activation test in food allergy. My name is Michele Romano. I'm a product manager in BÜHLMANN Laboratories AG, responsible for managing Flowcast, and I'm available afterward if you should have any further question. In BÜHLMANN are more than 20 years that we have launched our first version of the Basophil activation test. And today we are proud to be a unique company in the market offering the wood platform for BAT testing, comprising our lead product, the Flowcast, and more than 160 allergens that have been specifically developed and standardized for the use with our assay. Our mission is to bring Basophil activation test into the clinical routine laboratories. And for that, we are focused on any aspect related to assay standardization as well as on the clinical impact of the use of the assay itself. That's why we are encouraging and supporting research in this field and disseminating the clinical utility of that testing. Today, it's a great pleasure for me to introduce to you Dr. Alexandra Santos. In this webinar, she will present her experience with the Basophil activation test to diagnose food allergy, and she discussed the clinical utility of this test and further steps required to bring the Basophil activation test to the clinic. Alexandra Santos is a senior clinical lecturer and MRC clinician scientist at King's College London and an honorary consultant in pediatric allergy at Guy's and St. Thomas Hospital NHS Foundation Trust. Alexandra qualified in medicine from the University of Coimbra and completed a PhD in allergy and immunology at King's College London, supervised by Professor Gideon Luck. The focus of her thesis were diagnostic markers of clinical allergy versus sensitization to peanut, including the Basophil activation test, IgE, and the IgG4 testing. Alexandra continues to combine clinical activity with clinical and laboratory research to improve the diagnosis and the immune mechanism of food allergy and oral tolerance. Just before giving the words to Alexandra, it's just a communication. If you have any question during the webinar, you can write in the chat, and after the presentation, we can discuss it and ask directly to Alexandra. Thank you.
Thank you very much, Michele, for the kind introduction and for the invitation to participate in this webinar about the clinical applications of the Basophil activation test in food allergy. So this is the outline of my presentation. In this webinar, I will cover firstly the way we diagnose food allergy currently in clinical practice. Secondly, I will cover the utility of the Basophil activation test in food allergy. And finally, I will talk about the next steps to bring the Basophil activation test to clinical practice. An accurate diagnosis of food allergy is extremely important. If the child is not allergic, like the baby you can see on the left-hand side of your screen, we can broaden the diet and avoid unnecessary dietary restrictions that, when unsupervised, can lead to malnutrition and faltering growth. And if the child is indeed allergic, like the child on the right-hand side of your screen, we can identify which specific allergen they are allergic to and implement dietary avoidance measures to prevent the development of allergic reactions in the community that are potentially severe. So how do we diagnose IgE-mediated food allergy? And I will focus on IgE-mediated food allergy throughout my talk. So we base the diagnosis of IgE-mediated food allergy on a combination of the information collected with the clinical history and the results of the allergy tests, which can be skin prick tests and or specific IgEs. And we reserve the performance of oral food challenges for the equivocal cases. But oral food challenges are currently the gold standard to diagnose food allergy. So when a child reports a clear history of an allergic reaction to a specific food, the diagnosis can be quite straightforward if we can document the presence of IgE to that specific food. And we can confirm food allergy reasonably easily. However, more and more we see young children in clinic who have yet to eat the food in question. So for example, in the case of infants with severe eczema, that the parents are afraid to give peanut or egg or another allergenic food with the fear of causing an allergic reaction. And without a clear history, because the history is really the most important piece of information you can get to reach an accurate diagnosis. So without a clear history, the results of allergy tests can be quite difficult to interpret and can be often equivocal. And the reason for this is because the majority of children with positive allergy tests actually does not have food allergy. And here in this slide, I bring up the data from the Health Nut study in Australia. And as you can see, for example, for peanut, only about 1/3 of sensitized infants actually had peanut allergy when they were challenged. And similarly for egg and sesame. And this is also true to other foods and in other parts of the world. For some foods, 95% positive predictive value cutoffs have been identified. So for example, for skin prick for peanut, using skin prick tests, an 8mm wheel and above will have 95% positive predictive value or more. And for specific IgE to peanut, 15 kilunits per liter would be the 95% positive predictive value. These are cutoffs that have been determined in studies done in the United Kingdom and United States. And these cutoffs can be very useful to confirm food allergy, particularly in the presence of a positive history, of course. But they are not so useful to exclude. And if we look at the majority of patients tested, actually the majority of patients that are sensitized will have results below this cutoff. So in the sort of so-called immunological gray area. And so we'll have an equivocal outcome for the skin prick test or the specific IgE determination. For some foods, individual allergens or components are available to use for testing and can be more informative than the allergen extracts, depending on the food we are talking about. So for example, in the case of peanut allergy, Rh2 has shown in various studies to have a very good diagnostic accuracy. However, when we assess individual patients in clinic, we can find patients that have equivocal results for Rh2 specific IgE or have discrepant results in comparison with the clinical history. So for example, here on the right-hand side of your screen, you can see a representation of data from the Health Nut study again, where 18% of the infants tested with a positive challenge to peanut actually had an Rh2 specific IgE that was below 0.35 kilunits per liter. So when we are assessing individual patients and we get an equivocal result after doing a history and allergy tests, what we have to do is the oral food challenge, which is currently the gold standard to diagnose food allergy. However, the oral food challenges involve feeding the patient the food that they are suspected of being allergic to, so they have the risk of causing immediate type allergic reactions. They also have the risk of causing late phase reactions. They are resource intensive, so you need to have the equipment and the expertise, so you have to have an experienced clinical team prepared to treat severe allergic reactions, including anaphylaxis. With increasing frequency and awareness about food allergy and food sensitization, there is increasing demand for oral food challenges. And patients are often suspected of having multiple food allergies, so allergies to multiple foods, and ideally would need to be challenged to multiple foods. And finally, the oral food challenges are the gold standard, but they are not foolproof. They also have a small proportion of false negatives, small proportion of false positives, and also a small proportion of cases where we are left with an indeterminate outcome. And this can be because the child doesn't want to eat the food, or because the patients complain about subjective symptoms that do not comply with our definition of a positive challenge. And if we look at studies done in specialist centers, up to about 50% oral food challenges are positive. So about half of the patients, up to half of the patients undergoing an oral food challenge experience an allergic reaction during the challenge. And obviously this changes depending on the criteria for performing challenges in each center, but it's quite significant. And severe reactions can happen anytime, during any challenge, to any food. And in this graph, you can see a representation of the severity of the reactions happening during challenges to a variety of foods. And although the majority of severe allergic reactions happen when less than half of the food has been ingested, less commonly, severe reactions can also happen towards the end of the challenge. So whenever we do a challenge, we need to be prepared to treat severe allergic reactions at any stage in any challenge. So this is quite resource intensive and can be quite stressful for patients, parents, and healthcare professionals as well. So what is the utility of the basophil activation test in this context, in the diagnosis and management of patients with suspected food allergy? Well, the rationale to use the basophil activation test in this context is the fact that it can reproduce IgE-mediated reactions in a test tube and can potentially be seen as an in vitro surrogate of oral food challenges. So instead of exposing the basophils to allergen in vivo as a result of natural oral exposure, which is the consumption of food by the patient, and then looking and waiting for the development of allergic symptoms to develop that we know result from the degranulation of basophils and mast cells in vivo, we can look at the way the basophils in vitro respond to the allergen without having to expose the patient to the allergen. And there are a few studies supporting the role of basophils in IgE-mediated food-induced allergic reactions and anaphylaxis. So one of the classical examples is this study by Sampson et al. Published in the New England Journal of Medicine in the early 90s, where cases of fatal and near-fatal food-induced anaphylaxis were documented in the absence of detectable serum tryptase. So tryptase is a mediator that is mainly released by mast cells, but not by basophils. And in this paper, cases of fatal and near-fatal food-induced anaphylaxis, serum tryptase was hardly ever increased at different time points during the anaphylaxis episode, which supports the role for basophils in food-induced anaphylaxis. And more recently, in this elegant study by Scott Cummins and Tom Platts-Mills, where they challenged patients that had IgE to alpha-gal, and they challenged them with red meat, and showed that the basophil activation coincided with the development of symptoms during the oral food challenge. So the patients were challenged to red meat, and blood was drawn at different time points, hourly, during the challenge, and then they could see the ex vivo basophil activation at the same time that symptoms developed during the challenge. So again, supporting the relevance of basophils in these allergic reactions. How do we look at basophil activation using flow cytometry? Well, we have to stain the cells with antibodies for identification markers to be able to isolate the basophil population, and then activation markers to see what happens when they are stimulated with allergen in comparison with baseline. So with regards to basophil identification markers, we can use a combination of CD123 and HLA-DR, which can also will be associated with additional markers for improved precision, such as CD203C, which is specific for basophils. CCR3 and CRTH2 combined with CD3 are other possible combinations. IgE and so anti-IgE and anti-Fc epsilon R1 are not preferred, are not ideal, because they can change their expression with activation, and the expression can be different between patients, and it can be reduced when the basophils are activated. And it can also, depending on the protocol, they can also cause basophil activation themselves. When looking at activation markers, the most commonly used and preferred is CD63, followed by CD203C. There are others you can use, as you can see in this table, but CD63 is the one that's is best associated with anaphylactic degranulation. And the way the CD63 and CD203C behave in the basophil biology is different, and the results need to be represented in different ways. So, for example, and you can see here on the right-hand side of the screen, you can see CD63 in the graphs on the left, and then CD203C on the graphs on the right. And so, as you can see in the non-stimulated basophils, CD63 in the upper right quadrant of this plot is virtually not expressed. So it's not expressed in resting basophils. But when in allergic patients, when they are stimulated with allergen extracts, in this case peanut extract, then they become expressed on the surface. And the same happens with anti-IgE stimulation, which is an IgE-mediated positive control. So CD63 is best represented as a percentage of positive cells. When we are looking at CD203C in the far right of your screen, CD203C is constitutively expressed on the surface of basophils, as you can see with the blue curve in the top graph. And so the expression increases with basophil activation, as you can see in the red curve, either following stimulation with allergen and following stimulation with anti-IgE. So CD203C is best represented as a ratio of stimulated versus unstimulated cells. So it's better represented as a ratio of mean fluorescent intensity following stimulation in comparison with unstimulated cells. CD203C expression correlates tightly and directly with histamine release. This has been documented in various studies. Here on the right-hand side of your screen, you can see a figure from the seminal publication by Edward Knoll, where CD63 was first described as a basophil basophil activation marker. And so it was called monoclonal antibody 435 at the time. And as you can see, there was a direct and tight correlation with the percentage of histamine release. Since then, various studies have looked at the utility of the basophil activation test to support the diagnosis of food allergy, focusing on different types of food allergy, namely cow's milk allergy, egg allergy, wheat allergy, peanut and hazelnut allergies, and also pollen food syndromes, the hazelnut, apple, carrot, celery, for example. And generally, as you can see from the last two columns in this table, the sensitivity and specificity of the basophil activation test was very good. We have done a study here at St. Thomas's Hospital a few years ago looking at the utility of the basophil activation test to diagnose peanut allergy. So we recruited over 100 children that were being assessed for peanut allergy, and after the assessment were either peanut allergic or peanut sensitized but tolerant, meaning that they had IgE to peanut but were able to eat peanut without any problems, and non-peanut sensitized, non-allergic, so as controls. And as you can see from the graphs here, which look at the percentage of CD63 positive basophils in different concentrations of peanut extract, you can see that the basophil activation test discriminated very well the basophils of allergic patients here in red and the response of basophils of sensitized but tolerant or non-sensitized, non-allergic, which did not respond to peanut, particularly at the concentrations of 10 and 100 nanograms per ml that we found to be the most clinically relevant. We then went on to do a more detailed analysis, namely ROC curve analysis, to characterize the diagnostic performance of this test. So we have identified an optimal cutoff, which was the best balance between sensitivity and specificity, using data from 104 children, which constituted our primary population of the study. And in this population, whose data was used to generate the cutoff, the sensitivity was approximately 98% and specificity was 96%, with an overall diagnostic accuracy almost reaching 97%. We then recruited an independent population, prospectively and independently recruited, to validate these cutoffs. And in this second population, the specificity and positive predictive value reached 100%. Sensitivity and the negative predictive value were much lower, but actually it is the enhanced specificity that is the greatest advantage of the basophil activation test compared to existing tests that we currently use in clinic. In our lab, we've also tested the basophil activation test to 3 nuts, and this was using samples from patients recruited into the PRONUT study, which is a multi-center study led by Philip Eigenmann, Gideon Lack, and Antonio Nieto, with centers in London, Geneva, and Valencia, respectively, and where the safety and feasibility of introduction of nuts in the diet of children with at least one nut allergy was assessed. And so we have done the basophil activation test in 2 centers, London and Geneva. And as you can see from the graphs with this preliminary data, the basophil activation test discriminated very well between allergic and non-allergic patients, so with in red and blue, respectively, to the different nuts tested. In this case, the examples here are hazelnut, cashew nut, and sesame. We can use allergen extracts in the basophil activation test, but also single allergens. And depending on the food in question, they can be more or less useful. As you can see from the table here, for example, casein it was not better than using a cow's milk extract, and ovomucoid was only slightly better than using egg white in a Japanese study by Sato et al. Omega-5 gliadin was not really much better than using a wheat extract in this other Japanese study, but PRUP3, the LTP, the lipid transfer protein of peach, was actually much more specific than using a peach allergen to diagnose peach allergy in this Spanish study. In another Spanish study, this time looking at peanut individual allergens, this was led by Cristobalina Mayorga in Malaga. RH9, which is again a lipid transfer protein, which is an important allergen in that geographical location, was the best allergen, the best stimulant to distinguish allergic from non-allergic patients allergic to peanut. RH1 and RH2 was also statistically significantly different. We have also done basophil activation tests using single peanut allergens as part of the PRONUT study. We've tested alongside with peanut extract, we've tested these patients to RH1, RH2, and RH6 in the basophil activation test. And as you can see from this figure, all 3 components distinguished very well between allergic and non-allergic, but with the best performance being attributed to RH2. But the basophil activation test has quite a few practicalities involved in its performance. So, for example, it needs to be done quite soon after blood collection because the blood needs to be fresh, and it requires expertise in performing flow cytometry. So, realistically, it's not a test to be suitable for first-line testing to screen patients coming into an allergy clinic. In clinical practice, in patients with a clear history of a reaction to a specific food and large skin test or high specific IgE levels, we can diagnose food allergy pretty easily with conventional tests. And conversely, with patients with a history of consumption or no history of reaction and negative skin prick test or undetectable allergen-specific IgE, we can exclude food allergy with a good degree of certainty. The candidates, the patients that are good candidates for the basophil activation test to foods? Well, it's the patients exactly in the mid-range. So the patients that have sort of intermediate or low likelihood of allergy and intermediate range of sensitization. So to test this hypothesis, we have selected the subgroup of patients within the peanut study I told you about earlier, and we selected the patients that had an indeterminate outcome following a clinical history, skin prick test to peanut, specific IgE to peanut, and specific IgE to the 5 peanut components that we have available commercially. So RH1, 2, 3, 8. And looking at this challenging subgroup, the basophil activation test still discriminated very well between allergic and non-allergic participants. Looking at the ROC curve analysis in the graph on the far right of your screen, so the ROC curves for specific IgE and skin prick testing suffer, obviously, because of the way we selected this subgroup of patients. But the basophil activation test could also have suffered, and it didn't. It retained 92% diagnostic accuracy. So then looking at the number of oral food challenges required, if we use if we were to use the basophil activation test clinically and comparing it with our current strategy of determining skin prick test to peanut and specific IgE to peanut combined when we are about to decide whether a patient needs a challenge or not, we could see a reduction in 2/3 in the number of oral food challenges by using the basophil activation test alone. If we were to use the basophil activation test as a second step in the diagnostic workup, after skin prick test and RH2, for example, we would get a 97% reduction in the number of oral food challenges. But this would be at the expenses of about 2% of false negative results, which is really not desirable in clinic, because these are the patients that we say are not allergic, and then they can go home and eat peanut and then have a reaction that is potentially severe. So to be completely safe, we could decide to do the oral food challenges in patients with a negative basophil activation test. With that approach, we would still reduce the number of oral food challenges in about 2/3 again, so 67% reductions if we were to apply the results of our study in a real life situation. So our suggested approach for using the basophil activation test to diagnose food allergy is to start with the clinical history, which is undoubtedly the most important piece of information one can get to reach an accurate diagnosis of food allergy. Then we do skin prick test and or specific IgE, and depending on the results, we may need to proceed to an oral food challenge. And it is in these patients that would need to be referred for an oral food challenge that we can do the basophil activation test. And if the basophil activation test is positive, we can confirm food allergy with a high degree of certainty. If it's not positive, so if it's either negative or the patient has non-responder basophils, which happens in about 10 to 20% of individuals, where the basophils do not respond to any IgE-mediated stimulants, but only to the non-IgE-mediated, then we need to proceed with the oral food challenge. The first question that the patients ask when they are diagnosed with a food allergy is about the severity of the reactions, how bad it can be if they come across the allergen by accident. In our peanut study, we looked at the use of the basophil activation test to inform about severity and threshold of allergic reactions during the challenges. So we looked at the patients that had had a positive challenge, and then we classified the reactions that they developed as severe or mild or moderate. And then we also classified the threshold of reactivity based on the cumulative dose of peanut protein consumed, whether that was 0.1 gram or less, or more than that. And then we compared the results of the basophil activation test between the subgroups. And so on the left-hand side of the screen here, you can see the results for severe reactors in red and non-severe reactors in blue. And on the right-hand side of the screen, you can see in light red the results for patients with a low threshold of reactivity compared with the patients with a higher threshold of reactivity in blue. So what we saw was that patients with more severe reactions had a high proportion of basophils becoming activated at the different peanut concentrations. And patients with a lower threshold of reactivity had the dose response curve shifted to the left towards lower concentrations of peanut extract in the basophil activation test. We then selected the best marker to identify severe reactors and a lower threshold based on the basophil activation test, and we could see a highly statistically significant difference compared with patients with non-severe reactions or a higher threshold of reactivity. And results consistent with ours were subsequently published in a study performed in the US, where patients were recruited from Mount Sinai and Little Rock into clinical trials looking at the therapeutic effect of Chinese herbal medicine in food allergy. These were mainly patients with peanut allergy. And again, the basophil activation test discriminated very well between allergic and non-allergic patients, as you can see from the figures in the upper part of this slide. And the percentage of activated basophils was also directly correlated with the score, the severity score, based on the double-blind placebo-controlled food challenge. And these results were also consistent with results previously published in a cow's milk allergy study from Nice in France, where, again, the proportion of activated basophils was directly correlated with the severity score of symptoms during the challenge. and inversely correlated with the eliciting dose of cow's milk during the challenge. The Basophil activation test can potentially also be used to monitor natural resolution of food allergy. And in a study done in Mount Sinai, patients with cow's milk allergy were divided into different groups based on the ability to tolerate extensively heated milk. And looking at the results of the Basophil activation test in this subgroup, we could see that there was an intermediate, they showed an intermediate level of activation in response to cow's milk extract between the patients that were allergic to all forms of milk, that you can see in the far left side of the graph, and patients that had outgrown their cow's milk allergy, that you can see in the far right of this slide, and also controls. Another possible clinical application of the Basophil activation test is using it to monitor clinical response in allergic patients undergoing immunomodulatory treatments. And studies have reported basophil suppression during allergen-specific immunotherapy, the example. And the effect has been more marked with oral immunotherapy than sublingual immunotherapy, as you can see on the right-hand side of this slide. And interestingly, during treatment, basophil suppression was observed not only to the culprit allergen, but also to bystander allergen and IgE-mediated controls, but not non-IgE-mediated controls during oral immunotherapy to peanut. And these are results from this study by Schreffler and colleagues, represented here on the left-hand side of the screen. And but this basophil suppression in this other study, represented here on the right side of the screen, has shown to be transient, particularly after stopping the treatment. But what are the next steps to bring the basophil activation test to clinical practice? So as we could see from the previous slides, the basophil activation test would be useful as a second-line test in patients where, after doing a clinical history and skin prick test and or specific IgE, we have an equivocal outcome. So if the basophil activation test is positive, we can confirm the diagnosis of food allergy with a high degree of certainty and recommend allergen avoidance. If the basophil activation test is not positive, so it's negative or the patient has non-responder basophils, then we need to proceed for the oral food challenge. And this enables us to reduce the number of oral food challenges, and these are mainly positive challenges, which is really what's desirable in clinical practice. So, but how do we interpret the results of this test? Well, we have to be aware of various factors that can influence the performance of the basophil activation test, some that are common to other diagnostic tests and some that are specific for the basophil activation test, and that can influence the diagnostic cutoffs. So we need to be mindful of these, particularly when we try to extrapolate the results of published studies into our own clinical practice. So some of the factors that can influence the results of the basophil activation test have to do with the study population, others have to do with the study design, others with the procedures chosen for the laboratory, the laboratory procedure chosen for the basophil activation test, and finally for the flow cytometry data analysis. So, for example, with regards to the study population, as other diagnostic tests, actually, the basophil activation test results can be influenced by the prevalence of food allergy in that specific population, and whether it's the general population you're looking at or patients that have been referred to a specialized clinic. It can be influenced by the geographical location and associated respiratory allergies that are seen in that specific geographical location, namely pollen allergy. With regards to the study design, have to be mindful of the inclusion criteria for the study and whether it only included sensitized patients or also non-sensitized patients. What was the reference standard used to compare the basophil activation test with, if it was double-blind placebo-controlled food challenges or if it was reported food allergy reported by parents or patients? The criteria for doing oral food challenges, if there was a subset of patients that were not challenged or if all the patients were challenged, and also the oral food challenge protocol could influence the results. With regards to the procedure of the basophil activation test, The allergen extracts are extremely important. So the quality, the concentration range used, its stability, and the standardization throughout the study. The interval between blood collection and the performance of the basophil activation test is important, with a recent publication by Stephen Galley's group showing that it can be, the basophil activation test can be done up to 24 hours of blood collection. Pre-incubation with IL-3 can change the results, so it typically increases the expression of CD203C, for example, and can enhance the percentage increase in CD63. And then the markers that are used and the specific antibody clones and antibodies that are used for staining identification and activation markers can also influence the results that you get with the basophil activation test. And then finally, flow cytometry procedures, so the equipment that is used, the application settings, the gating strategy that is adopted, and the parameters that are used as the outcomes of the test, if it's percentage of activated cells, if it's the concentration that you see half maximal reactivity, if it's the area under the dose response curve, the definition of a negative gate to which you compare the results of stimulation versus unstimulated cells, and then whether the results are corrected for the background, whether it is the baseline basophil activation is subtracted or not. So these are all factors that can influence your results. And with regards to flow cytometry data analysis, that has been a recent publication by Severity and Wayne Schreffler proposing a method to do automated data analysis, which is interesting and can reduce this stage of generating the results of the basophil activation test, which is quite time consuming, and it can also improve the standardization of these analyses. So essentially, the roadmap to bring the basophil activation test to clinical practice involves 4 different stages. So one of them is standardization of the laboratory procedure, so reagents, allergen extracts, the protocol, the flow cytometry methodology. Then the standardization of the flow cytometry data analysis and of the parameters that are selected as the outcome of the test. Then clinical validation of the studies, of the tests, so with diagnostic studies, and these need to be done for different food allergens and in different clinical populations. So we can extrapolate results from populations, from studies done in populations that are similar to the one that we see in clinic. But if we are have a different type of population, then we need to do our own validation. And then finally, particularly if the basophil activation test is already in clinical use, it's important to assess the impact that it has on patients' health outcomes, on decisions, clinical decisions, namely to perform challenges, its cost effectiveness, and the overall benefits for the life of the patients. So, to conclude, the take-home messages from this webinar are that the basophil activation test has high specificity and sensitivity to diagnose food allergy and can be used to monitor clinical response to treatment and possibly natural resolution of food allergy. If a basophil activation test is positive, we can confirm the diagnosis of food allergy and avert the need for oral food challenges, and these are mainly positive challenges. If the basophil activation test is negative or the patient has non-responder basophils, then we need to proceed for an oral food challenge. And finally, in order to make the transition to clinical practice, standardization of the laboratory procedure, flow cytometry and data analysis are required, as well as rigorous clinical validation and assessment of the impact of the basophil activation test on health and social outcomes and cost effectiveness. And so finally, I would like to thank, well, firstly, patients and their families for participating in the studies that we've done. We are very grateful to them. And then all my colleagues in the lab, statisticians and my colleagues in the clinic, and also BÜHLMANN Laboratories for providing reagents for performing the basophil activation test in the PRONET study, and obviously my funders, so the Medical Research Council and the Immune Tolerance Network and the NIH. And thank you for listening.
Thank you, Alexandra, for this very interesting presentation. Now we can be open to some questions from the audience. And just before receiving some of the questions, I can start with one from me. do you have an idea of how big is this number of equivocal cases during your daily practice? Which is I would say, can you estimate which could be the impact of the use of Basophil test once introduced into the daily practice?
So, so in terms of the results of the tests on their own, so thinking about, for example, peanut allergy, which is the one we have studied best at the moment. So just thinking about the results of skin prick tests or specific IgE to peanut on their own, I would say a bit over 50% of the patients would have an equivocal result. But obviously in clinic, we take that into account together with the history. So it really depends on the history. So probably we would be, below the 50% range in terms of the patients that would need further testing.
Okay. There is of course, one of the first questions that is coming. What is the cost of blood testing?
Well, I mean, the cost depends on the reagents that are used, the methodology that is used, because this can be quite different when considering a commercially available kit or when using your own in-house protocol. So the cost is quite different, but the main cost would actually be the time of the operator, really, and that also depends on the country where this is performed. So I think the cost can be quite variable, but depending on the methods used and the setting where it is applied. But I would say that the cost is obviously higher than skin prick test or specific IgE, but much lower than oral food challenges. So for example, in our own setting here, I would say that the costs of the basophil activation tests are, yeah, I mean, like, 5 times less than the cost of oral food challenges, if we just think about financially. But it all depends on the setting.
Okay. Another, I think this is a more technical question. It is possible to perform blood test immediately after the skin testing?
Yes. Yeah. I mean, from a medical point of view, yes, definitely. Patients can have skin tests and then can have blood collected for the basophil activation test. It all obviously, in terms of like time of the day when the blood is collected and the time to performance of the basophil activation test, then it will be, the feasibility will be influenced by the ability for the lab to respond. But yes, I mean, theoretically, you could see a patient in clinic, and then if you have an equivocal result based on skin prick testing, and we often do that, we often send the patients for blood testing after doing skin prick testing if the results are equivocal. And so blood could be collected for specific IgE and for basophil activation testing. And then those tests could be done after skin testing. That is feasible. But obviously we need to have ability from the lab to respond to that, because the basophil activation test should be done either on the same day of blood collection or within 24 hours.
Perfect. I have a couple of questions that are more or less the same, that are related to the IgE non-responder. One is what percentage of anti-IgE non-responder have a true peanut allergy, and if you have any insight to explain this phenomenon. And the other is more technical question, is that related to this one, is if there are any ideas to modify but in a responder to turn them into responders.
Yes, I mean, these are very good questions. So from a practical point of view, about 10 to 20% of individuals have non-responder basophils. So these are basophils that are there's no response to any IgE-mediated stimulants. So there's no response to anti-IgE, anti-Fc epsilon R1 or allergen, but there is a response to non-IgE-mediated stimulants. The majority, in our own hands, so the vast majority of these patients are not allergic, but we've also had a few that are allergic. So we've had a couple of patients that had out of the 100, so over 100, so it's something between 1% and 2% that actually are allergic. So on the same day that they are undergoing a peanut challenge, the basophils in the lab are non-responding. So that's why we can't really conclude anything when we have no response to the IgE-mediated control and no response to the allergen, because a minority of these patients could be allergic. So from a practical point of view, non-responding basophils is an inconclusive result for the basophil activation test. Then why this is happening? I mean, there is quite a bit of literature by Donald McClashen and others looking at the biology of basophils in these cases, and there seems to be deficiency in the response of the cell itself. So there, namely Syk and other signaling molecules involved, and this seems to be transient. So this can be changed. For example, when culturing basophils in different conditions, namely with IL-3, for example, this can be enhanced. We haven't actually in our own lab tested, some patients with different conditions to see if we can change the results. And patients that had non-respondent basophils at one time point, sometimes later on don't have. So this is variable. We have worked with other types of assays where we passively sensitized cells with the plasma of these patients, and so where the cells do not belong to the patient, and there we actually are able to get a result for the basophil activation test, so we can obviate this non-responding. But obviously this is more mechanistic experiments. I mean, I wouldn't necessarily use that for diagnosis, but I mean, practically, when you're doing the whole blood basophil activation test with non-responding basophils, have an inconclusive outcome, and you can't really trust, you can't consider that negative.
Perfect. Yeah, I think this is absolutely an interesting matter of research. I think that I can just ask you two very quick questions that are much more technical. How long does it take to get a result of that test?
Well, in terms of the laboratory procedure, again, it depends on the method that is used, because different protocols can be applied. There are protocols where cell stimulation and staining are done at the same time in the same step, and the washing steps are minimized. There are other methods where cell stimulation, staining, and are all done as different steps, so they can take a bit longer. And also flow cytometry can take variable amount of time, but I would say that's something between 3 and 5 hours. And it also depends on the number of allergens being tested, of course, because the more the higher the number of allergens, then the more time you take to do all of that, and also whether a full allergen dose response curve is done, or if just single allergen concentrations are used, can also vary the number of conditions you have and the time that it takes. But I would say something like between 3 and 5 hours, you can have the results, and then you need to analyze the flow cytometry data. So yeah, I mean, I think something between 5 and 7 hours, and you'll have the results of the basophil activation test for sure. Okay.
I think that we can close also with the question, and in case because we get other question, maybe we can directly reply by mail to those questions. Alexandra, once again, thank you very much, and of course thank you to everyone attending the webinar. And if you want to reach out to us, please use the contact information provided in the webinar emails or via our website, that is the BÜHLMANNlabs.com for the North America, or .ch for any other country and Europe. Alexandra, thank you again.
Thank you, Michele. Thank you.
We can consider close the webinar. Thank you.